This video is going to be on sleep and seizures. So we'll talk about sleep first. Now, what regulates your sleeping rhythm, your sleeping cycle? We talked about it before. That'd be your suprachiasmatic nucleus of your hypothalamus. And we said that your suprachiasmatic nucleus has a lot of input from things like your eyes, where it sees it's daylight, I'm not supposed to sleep now. When it sees it's dark, nighttime, okay, now I'm going to sleep. So it has input from your eyes. It also gets input from hormones. So things like melatonin. Melatonin, what makes melatonin? That'd be your pineal gland. Things like norepi. Wait a minute, norepi, isn't that the thing that mediates alertness? Well, in this case, norepi is made from your suprachiasmatic nucleus, and norepi tells your pineal gland to make more melatonin. All right, so it kind of works around that. And this all helps you go to sleep. Now, what are the stages of sleep? Let's say you're about to go to sleep. So you lie down in your bed, you're still awake, then you kind of close your eyes and you start drifting off into sleep. So you start when you're awake, then you kind of close your eyes. I'll say eyes close, and then you start drifting off. And we can break sleep down into two different categories. You're either in the deepest stage of sleep, which we call rapid eye movement, REM sleep, or you're not. So we break it into non-REM, which is N sleep. So right, non-REM or REM sleep, REM. All right. So we'll talk about the first stage first. When you're awake, your brain's still working, your brain's still thinking. And if you scan the brain, if you put some electrodes and scan the brain, you'll see it working. You'll see high frequency firing because your brain's still thinking, still working, but it's low amplitude. So we call these beta waves, beta. These are high frequency, lowest amplitude. And when your eyes close and you're starting to get more calm, trying to go to sleep, the waves will change and become alpha waves. Now you're finally getting into light sleep, non-REM sleep. We can break this non-REM sleep into different stages. We can break it into N1, N standing for non-REM, 1 standing for the first stage. N1, this is light sleep. And you'll see theta waves. But as you progress, you'll go into a deeper sleep and you'll go into N2. And N2 is where we spend the majority of our sleep. N2 we'll see these waves that kind of look like this. That looks like an ECG, but you'll have to take my word for it. It looks kind of like this. This small squiggly line is called sleep spindles. Sleep spindle. This kind of spike is called a K complex. Not much is really known about what they do because we don't really know how the brain really functions, to be honest with you. But it seems that these play a role in inhibiting your waking. All right, so it keeps you asleep, keeps you under. You keep progressing, you go into N3. N3 is also known as slow wave sleep. This is the deepest non-REM sleep. This is as far as we can go before we hit REM. Slow wave sleep. So, all right, deepest non-REM. And the waves you're gonna see are gonna be very low frequency, hence the name slow wave, because low frequency, slow. But it's going to have very high amplitude. So this is going to be the slowest, but the highest amplitude. And here, you're very difficult to arouse, very difficult to wake, but you can still move. That poses a problem because in here, in N3, in your slow wave sleep, you're going to see things like sleepwalking, talking. So you're moving, you're talking, but you're difficult to arouse. So someone that's sleepwalking, they're doing all these things, but when you try and rouse them, it takes a lot. And when they do rouse, when they do awake, is that proper grammar? But when they do wake up, they're way out of it. Okay. So this is walking, talking. You can even pee. This is bedwetting, enuresis. You can have tears where you're shaking, you're screaming, you're yelling, but you're still kind of under sleep terrors. This all happens in N3 sleep, okay? But let's say we keep progressing and we finally hit REM. REM stands for rapid eye movement. This is, in this part, now your body turns off. Now your motor function stops. So I'll write loss of motor function. In some regards, it's good, because this is where we have our most vivid dreams, and we don't want to be actually moving when we're having our most vivid dreams. So your brain is going to be very active, brain active. It's going to consume a lot of O2 because it's so active. You're going to see a lot of ACH because it's so active. You're going to kind of feel these dreams at a visceral level. So you're going to, if you're having, like, you're dreaming or you're being chased by a cheetah, you're going to feel your pulse pound, your blood pressure will raise. So, all right, pulse, blood pressure, all these will respond to dreams. This is also where your sexual organs can respond. You can have penile erection. We call that morning wood. I'll just write erection. And these deep REM dreams seem very lifelike. In fact, if you look at your brain, you're going to see waves that look just like when you're awake. So you're going to see beta waves in REM sleep. You kind of go full circle. That is how you sleep. That is your cycle of sleep. Now, do you go from awake to REM and then you kind of stay there? No, you kind of go from REM back to non-REM, back to REM, back to non-REM. You kind of cycle around. It takes about like 90 minutes. You kind of just keep cycling until you wake up. And that is how you sleep. Now, some sleep disorders, well, you can have all of what we talked about. You can have sleepwalking, sleep talking, enuresis, peeing yourself, sleep terrors. Some things we can do to kind of dampen these symptoms. Well, we can do conservative therapy. So if a patient has a problem with peeing in the bed, then try to drink less water, try and use the bathroom before you go, all that stuff. But if you're talking about medications, well, we can give some medications for sleep enuresis. So bedwetting. We can give ADH analog, aka desmopressin. That holds in water and stops you from bedwetting. We historically used to give something called imipramine, which was a TCA, tricyclic antidepressant. You might need to know that. Imipramine. And this antidepressant was so non-specific that it had antimuscarinic effects, which made you have constipation, which made you retain your urine, and we use that urine retention for bedwetting. Right. So that is sleep. That was pretty easy. Let's talk about seizures. Now, seizures is due to overactive firing in your brain. Neurons firing when they shouldn't fire. Sending signals when they shouldn't send signals. So let's just recap. This is your neuron with your dendritic projections. It will receive signals, process it in its cell body, and then send a signal down its axon. Terminals will release neurotransmitters, and the process will repeat itself. Now how do you release those neurotransmitters in the first place? Take a section of this axon terminal, when your neurons get a signal, then sodium channels will open. Sodium channels will open and depolarize the cell and send a signal down, all the way down to the terminal. So fill that signal and depolarize, and I'll open calcium channels. Calcium will influx, and that calcium influx will cause the release of vesicles full of neurotransmitters. And that is how you release those neurotransmitters. That's how you send signals, essentially. And in seizures, for some reason, you're sending too much signals. You're doing too much, essentially. Our bodies have ways to regulate how frequently you fire your neurons. We do that through excitatory neurotransmitters and inhibitory neurotransmitters. So excitatory would be your glutamate. Inhibitory would be your GABA. We think that seizures occur because there's too much nerve firing and there's too much excitatory neurotransmitters, glutamate. And there might be possibly too little inhibitory neurotransmitters, GABA. And by throwing that kind of balance off, you have increased frequency of firing and you have seizures. This is the general gist of seizures. Now let's talk about some finer details. Well, seizures, like I said, are abnormal firing. And you can have one seizure and never have it again, but sometimes you can have recurrent seizures. Recurrent. And if you have recurrent seizures, we call that epilepsy. Also, you can have seizures, you can have abnormal firing that lasts a split second. Or you can have abnormal firing that lasts for 20 minutes. If it lasts more than 5 minutes, a seizure lasts more than 5 minutes, we call that status epileptic. All right, 5 minutes, and when you have so much firing, it can be neurotoxic and you can have brain damage. All right, there's many causes of seizures depending on the age group. In kids, it can just be from an infection. You can get a febrile seizure. In adults that have never had seizures before and they all of a sudden get it, especially if they're older, then one of the most common causes is a brain tumor. So that warrants a brain scan right away. In older patients, you might have strokes. You can also have tumors. So the causes of seizures differ, but the mechanism is all the same. It's abnormal firing of your neurons. Now, there are many classifications of seizures, and I think the nomenclature throws a lot of students off, so let's try and simplify it. Seizures can be broken into two groups. They either affect a part of the brain, one part of the brain, one hemisphere. We call that partial seizure. So there's one hemisphere. Or it can affect both hemispheres, just your general brain. We call that generalized. And that's both hemispheres. And then notice that in generalized seizures, when it affects your general brain, you have loss of consciousness. So LOC, loss of consciousness. In partial, sometimes you can have it, sometimes you don't. And that's how we separate partial. Sometimes you have loss of consciousness, sometimes you don't. So I'll say no loss of consciousness, and then loss of consciousness. Let's talk about partial first. Partial is when it affects one part of your brain. That's why I call it partial. What part of the brain does it like to affect? It likes to affect the medial temporal lobe. That's your temporal lobe. That's more midline. And you can either have loss of consciousness or no loss of consciousness. If you don't have any loss of consciousness, we call it simple partial. Simple partial. So you still have consciousness, but you're just exhibiting some sort of symptom from the seizure. If you do have loss of consciousness, then we call this a complex partial. And you'll exhibit those symptoms, but you won't know because you've lost consciousness. So commonly, they call it automatism. Automatism. Basically automatic. You're doing these motions automatically. You have no awareness. You're blacked out and you're doing it. So you might black out and then you might start lip smacking. We'll take that for example. So you just be, and then you'll flash back and you won't realize what happened. So that is partial seizures. Now let's talk about generalized seizures. Generalized seizures affect your general brain, both hemispheres, and there's always loss of consciousness. So we can't categorize the different types of generalized seizures due to loss of consciousness because they all have loss of consciousness. So we instead break it down into the symptoms. The first one is absent. They call it absent because it looks like you're absent-minded, you spaced out. You lose movement, loss of movement. Usually it manifests itself as a kid that's staring into space. You can't get their attention. And then suddenly they snap back to it. So they lose movement, usually seen in, I'll just say staring. Usually it looks like they're just staring off into space. If you scan the brain during this time, you see very characteristic findings, and that's 3 megahertz spikes. So kind of spikes. I need to stop drawing these, they look like ECGs, but just take my word for it, 3 megahertz spikes. So that's absent. The next category is categorized by the symptom of muscle jerks. We call this myoclonic. Clonic means jerk, myo means muscle, so you have muscle jerks. Muscle jerks. Usually happens early in the morning. That's it for myoclonic. Next up, tonic-clonic. Tonic-clonic. Tonic means stiff or stiffening. Clonic, we already said, means jerk. Jerk. So it is alternating between stiffening and jerking. A lot of times they show up as they'll stiff up and they'll fall down. Then once they fall down, they'll start jerking. So that's tonic-clonic seizure. That's kind of like the classic, I guess, the stereotypical seizure you'll see on movies or stuff like that. So fall, and then they'll start jerking around. And then the last one is going to be your atonic. If tonic means stiff, atonic means a loss of all stiffness. So you basically collapse. You just drop and melt to the floor. You need to make sure your differentials include things like syncope or passing out, because they look very similar. So I'll just say drop to floor. And these are all your different types of seizures. Now, let's talk about seizure medication. We know the mechanism. We know the pathway. We said sodium channels open, depolarize. And then that depolarization will open your calcium channels and your vesicles will release neurotransmitters. And then we have some sort of imbalance between firing and excitatory glutamate and inhibitory GABA. When we throw off that balance, we get our seizures. That's our mechanism. So our drugs will kind of work on this pathway. One of the big ones is going to be sodium channel blockers. You block that initial sodium channel from opening, you kind of block that nerve impulse. So NA blockers. These include things like Phenytoin. Now, Phenytoin is a zero-order kinetic drug. That means it will excrete itself at a fixed amount no matter how much you take. Just an example, if your body excretes Phenytoin at 1 milligram an hour, it will excrete that same 1 milligram an hour no matter if you take 10 milligrams or if you take 1,000. So it makes it very, very easy to reach a toxic level. And you should know the side effects, because the side effects are numerous. Side effects include gingival hyperplasia. That means your gums are growing way too fast. Hirsutism, so hair growth. You can have lymphadenopathy and fevers, so we call it pseudo-lymphoma. And you should know it is a teratogen. Don't give it to a pregnant woman, because it can cause hypoplasia of the nails and your distal interphalangeal joints. So you can have hand deformities as well as other deformities. So hypoplasia of nails. DIP. All right. The next sodium blocker is going to be carbamazepine. Sodium blocker, and it also potentiates GABA. So try and raise those levels. Try and bring that balance back in place. Carbamazepine is great for neuropathic pain also. Stops the firing of nerves that cause neuropathic pain. We talked about when we talked about trigeminal neuralgia. Then we use carbamazepine for that. So I'll write neuropathic pain. And it's very similar to Phenytoin. They're both sodium channel blockers. They're both teratogenic. Except this time it causes neurotube defects. The unique side effects include things like agranulocytosis. Hopefully you remember that. We said if someone takes carbamazepine, you monitor their bloods. Make sure they don't have agranulocytosis. That is the biggest one, but they can also have different things. They can have SIADH, too much ADH, too much water retention, hyponatremia, etc., etc. So carbamazepine is a big one. Now those are your sodium blockers, and we said carbamazepine also potentiates GABA. Let's talk about other things that potentiate GABA. So I'll write GABA potentiators. I don't know if potentiators is even a word, but these are things that increase GABA, kind of bring that balance back in place. Things that increase GABA will be your valproic acid. And it increases GABA by decreasing its metabolism, decreasing its reuptake, kind of leaves more GABA in the synapses. Valproic acid is a big one. And it can be used for all seizures, which sounds good, but you gotta know the side effects. Side effects include alopecia, it's hepatotoxic, pancreatotoxic. Pancreatotoxic is totally not a word, but it can cause pancreatitis. And is a teratogen, causes neurotube defects. Other GABA potentiators are things like vigabactrin, tiagabine. All these potentiate GABA. So we talked about GABA, we talked about sodium. Let's talk about calcium. Calcium blockers. If we block calcium, then we kind of block the vesicles from releasing. So calcium blockers include things like ethosuximide. This is a calcium blocker. And this is great for absent seizures. I've gotten a ton of questions on it. They'll talk about a kid that's staring out into space. They can't get their attention and then they kind of snap back, which means they're having an absent seizure. What drug do you give them? Ethosuximide. All right. And then we're going to just talk about a couple more drugs that don't really fit into any category. Lamotrigine. This blocks sodium, and it also inhibits glutamate. Inhibits that excitatory neurotransmitter, again brings that balance. So it kind of does both. The main side effect you need to know is that it can cause Stevens-Johnson syndrome. Seems to be an increased risk for, I mean, it's a risk for any drug, but it seems to be a very high risk for lamotrigine. Next is topiramate. And topiramate seems to work on a lot of different mechanisms, but it can be used for seizures. It can also be used for headache prophylaxis. Headache prophylaxis. You should know the side effects. Things like kidney stones, things like sedation, things like weight loss. It was used off-label for a while for weight loss, all right? But there are also side effects you should know: kidney stones, sedation. So these drugs can all treat seizures, but we said that sometimes seizures can last a second or they can last a very long time. We call that status epileptic. And when you have someone that's having those really long seizures, our first drug is actually none of these. Our first drug is actually something that potentially is GABA. It's benzos. Benzo is your drug of choice for status seizures. You gotta know that. So the questions I've seen, someone will come in seizing for 10 minutes, and then what drug do you give them? You give them benzos. All right, so look in the answer choices for a benzo. These drugs are great for working in the brain, stopping seizures, but they can also work someplace else. They can also affect your liver cytochrome P450 enzymes. They can induce them, which means you metabolize drugs faster. So if you're taking these drugs, that induce it, and you're also taking like oral contraceptive pills, and you can theoretically really metabolize that OCP quicker than you should and get pregnant. So you can have drugs that induce your P450 enzymes. These are going to be, how I memorize it, PCP. P stands for Phenytoin. C stands for Carbamazepine. And the other P stands for phenobarbital. Phenobarbital is a barbiturate that you can use for seizures. But just know that PCP induces P450s. Now, what can inhibit it? Inhibit P450 and make metabolism of drugs slower, which means you can have more side effect of whatever drug you're taking. Inhibitors include valproic acid. So if you just remember PCP and you remember valproic acid, I think you'll be in good shape in terms of seizure drugs. That does it for sleep, seizure, and seizure pharm. Hope you enjoyed the video. Thanks.